right. This is our title slide, and I'm going to turn it over and have each of our presenters come on to introduce themselves. We'll start with Dr. Michael Long.
Hi, everybody. My name is Michael John. I'm an emergency physician at Baylor College of Medicine. I've been the physician advisor for the Patient Discharge Initiatives for a few years. I'll be talking a little bit more about that in the presentation. Next is Abby.
Yeah, hi, my name's Abby Castro. I'm a rising junior at Rice this year, and I serve as one of the PDI co-presidents.
Hello, my name is Jordan. I'm another one of the co-presidents for PDI, and I'm a rising senior at Rice University.
Hi everyone, I'm Andy Liu. I'm also a rising senior at Rice, and I serve as a research co-head as well as a shift leader.
Great. Thank you all for being here. I'm going to turn it over to you for the presentation.
Perfect. So I'm going to start off by talking a little bit about the history of the organization. The Patient Discharge Initiative was founded in 2011 by two medical students at Baylor College of Medicine with support from the Albert Schweitzer Fellowship. It was started as a project to tackle disparities in healthcare access. And the overall mission has stayed the same throughout many years to really improve post-hospital quality of life for underserved patients at Ben Taub Hospital, medication adherence, improvement of follow-up appointment adherence, and distribution of medical, social, and financial services and resources. I started getting involved. So I started working at Harris Health and Ben Taub in 2013. I got involved with the organization around 2016, 2017 to help with quality improvement and evaluation. For me, it was really exciting to get involved with this organization, really to address sort of things that we see every single day with almost every single patient that we encounter in our emergency department, and really providing a way for patients to seek help, chat for help, and discuss more opportunities for help than maybe what nurses, physicians, and other providers can provide in the immediate time frame in the emergency department. Next slide, please. For those of you not based in Houston, I'll give you a little bit of background about Harris County, Harris Health, and Ben Taub Hospital. As many of you know, Harris County is the third largest, most populous county in the U.S. It's served by the Harris Health System, which has a total of 160,000 annual ED visits across two hospitals, Ben Taub Hospital and Lyndon B. Johnson Hospital. The map here on the right is Harris County with the map of the Harris Health System facilities. Lyndon B. Johnson Hospital is a little bit north of downtown, and Ben Taub General Hospital is in the medical center a little bit south of downtown. Our emergency center at Ben Taub is a level 1 trauma center, comprehensive stroke and chest pain center. There's over 80 treatment rooms. The physicians, advanced practice providers, and residents are from Baylor College of Medicine, and we have medical and other health professional students from many different institutions. We are really lucky to have a lot of nursing and allied health across the emergency center, and we also have in-house 24-hour social work and case management services. The overall Harris Health System is these two large hospitals, in addition to 16 community health centers. We also provide the services in the county jail system. Harris Health has a dedicated population health program, which we'll talk a little bit at the end. And then lastly, for patients without insurance in Harris County, we have the Harris County Financial Assistance Program, which is colloquially known as the Gold Card. It is a financial aid-based system for patients that are 100% 150% below the federal poverty line. Next slide, please. Just to summarize a little bit of our activities, we're going to focus most of our presentation on sort of the nuts and bolts and how we run the organization. But we did a retrospective review of the previous 2 years, December 2023 to December 2025. In this 2-year period, we reached 1,300 patients in the emergency department. Of these patients, approximately, this is all self-reported, 36% were self-reported as only or primary Spanish speakers, 37% reported having no insurance and no financial assistance. Overall, it was about 70% of patients that either had no insurance, and about 30% of those patients had the Harris County Financial Aid Assistance Program. The vast majority of our patients reported a social need on screening, 80%, and 72% of the overall patients received resources. The most common resources received were related around food, so low-cost food assistance resources and then specific enrollment in the SNAP program information. As you can see in our flow chart on the right, we have our reaching the patients in the emergency department, and then we have a follow-up phone call system. Over this 2 years, we had a 58% follow-up rate for patients at 1 week, which if you look at comparable studies for phone follow-up for patients in the emergency department, this is about double the usual successful phone follow-up rate for when we reach patients that have left the emergency department. So with that, I'll transition to the next slide and to our next speaker.
Great, thank you. So as mentioned earlier, Dr. Zhang, our physician advisor, really allows us to continue research at the hospital, and Andy, who is on the meeting, will talk more about that towards the end. But I also wanted to acknowledge the importance of additional institutional connections for an organization like this. So when we're looking to replicate an organization at another institution, we're not trying to reinvent the wheel. That means finding a hospital with pre-established infrastructure that already supports student volunteers at any level. That can be medical students, undergraduates, even high schoolers. That's something we look for, and when we look to expand it, that's something specifically we look for as well. So what we then do is bring in our existing responsibilities of those student volunteers, and we can expand on that with what we do here at the Patient Discharge Initiative. So at Ben Taub specifically, Ms. Courtney Hoyt is critical to this. She's a senior manager of volunteer services and really is the point of contact we rely on when it comes to what volunteers can or cannot do. Once again, continuing on that theme of not exceeding responsibilities beyond what are already created for us. The key takeaway here is that all of our volunteers are credentialed through a streamlined process handled by Ms. Courtney Hoyt, and this allows for our organization to work through less red tape as we expand our responsibilities. So quickly, just for the club composition, we have about 92 Rice undergraduates, and within that, 25 are shift leaders, and 8 committees make up that student body, and I'll get into what those committees are. So then a little bit more of an expansion on that. The student body is composed of 2 co-presidents. That's Abby and I, and that changes every year through election. 30 board members, which are students who vote on constitutional changes. And then the board members are made up of shift leaders and then committee chairs. So now we're going to get into the committee. So what specifically are these committees? Well, these are among the most important parts for both student engagement and for us to make long-lasting change at the hospital. Essentially, they are specialized student groups that work on projects that can span a semester, a year, or even multiple years when it comes to the research committee, for example. So I don't want to spend too much time on the specifics for each one, so we're going to go through one by one, just quick responsibilities. So volunteer education, they focus on training shift leaders for each semester, and we'll talk about that importance. And they also hold our fall and spring training for new and existing organization members. Then we have patient education. They're in charge of updating our current resource lists that we deliver to patients, and they update it with current information, current contact details, eligibilities, all of that important information. And a challenge we actually encountered here was not having a frequent process for updating that resource. So we now added to our constitution yearly an amendment that allows for yearly reconstruction of our resources that align with Ben Taub's what they approve. The next one is health policy. They focus on educating members on careers in health policy, as well as current initiatives available to them around Houston and even around the US. The next one after that would be community outreach, and they focus on partnering with external organizations outside of both Rice University and Ben Taub Hospital. So for example, we've previously partnered with Be the Match, if you're familiar with that organization. And they also host our annual Social Determinants of Health in Houston Symposium, which invites multiple organizations that help us understand further how to complete our work. And the last one is expansion. And this talks about moving into additional clinics. Right now, we're in talks to move to additional clinics within the Harris Health System, as well as to other universities. Okay, so the large takeaways here and the lessons I want to talk about within our structure is that having both the committee heads and committee members really allows for longevity across generations of college students. That's very difficult with an undergraduate institution doing something like this because you have students constantly graduating. But this allows the committee heads to choose the next committee heads for the previous year, for the next year, from the group of students that they lead, which allows for gaps to be reduced. And that way projects can continue without there being times where work isn't being done or information isn't being passed down. The next one is that student board meetings are imperative in keeping our committee heads and our shift leaders accountable in their work. What we utilize is a live document to help everyone keep track of other committees' initiatives. This is really useful for accountability, but also for committees to understand how they can work together and understand how they can work on each other's projects. So on the next slide, I have here just a quick example of what that looks like. And that's just committees here on the left with the project names, what they currently need, and then the project descriptions and what we're working on. And this is really useful when we're talking about letting these committees interact with each other. So the next one is we found that having these semi-autonomous committees lets the project get done faster and more efficiently, because not every decision has to go through the co-presidents. Instead, they centralize their decisions in the members and the committee heads that know the project best. And really that allows the co-presidents to act as support, while the committee heads like Andy can get more work done that way. And then last, what we're looking to improve is getting more institutional support, like I talked about earlier. The research committee is heavily helped with Dr. Zhang and his credentials and his experience, and that's something we're looking to expand to other committees, and really something that can be done when we're looking to replicate this at other universities. For the next slide, one of the major challenges I want to talk about that we experience is how to properly prepare new volunteers for the clinical environment. Ben Taub is a safety net institution, which means many of the conversations are going to be surrounding social needs. Because of this, one of the most important committees is volunteer education. An aspect that we work specifically hard on is preparing them for those sensitive conversations, as I mentioned, because many of them are first volunteers, some of them are even freshmen in college, and our trainings are constantly in flux to better account for improving upon this process. Shift leaders specifically who train the volunteers on site are screened for conflict management and cultural competence, something that's really imperative in a setting like Ben Taub. So this is a quick excerpt on this next slide from our fall training document. The important thing to get out of this, sorry, could you click one more, please? I appreciate that. Really, the important thing to get out of this is just a quick example of when we treat just how to talk to patients in this clinical setting. Remember, a lot of these patients are encountering volunteers who maybe have never encountered a patient before, who had never done any healthcare work in high school. So training this really from the ground up is something we really focus on. And then once we build on simple ideas such as empathy, we get into more advanced ideas such as bias in our cultural ideas and cultural competence, and understanding how to navigate that sensitively when we offer certain social resources. Okay, so great. On this next slide, I'm going to go quickly through some challenges we have experienced throughout the student recruitment process. The whole process from applications to interviews for us takes about a month and a half. But the important takeaway here, next slide, please. The important takeaway here is that we run shifts, 14 shifts across 7 days a week. And that was decided in agreement with both Courtney at Ben Taub, as well as with our capabilities over at Rice University. And something important is that we learned to make that schedule based on a couple of key factors. That considers the number of students a shift leader or two can meaningfully train without disrupting the hospital proceedings and the work we want to do at Ben Taub. It's also important to consider the actual need at Ben Taub, how many patients get in at certain days of the week and the times that we actually volunteer. The number of students we then can train each semester during our group trainings that end up being quite large. And then the application capacity and how many students we can reasonably allow into the organization every semester. So then, speaking of applications, we recently made a change in our application process to combat an issue we were seeing. Around 45% of patients from a 2020 report were of Spanish-speaking nature. And that's very important because all of our members, while they're trained on how to use translator services at Ben Taub, that doesn't necessarily mean they're comfortable on holding those conversations alone. And that could reduce the quality of our interactions when we're talking about social work. So we recently approved a new constitutional change that slightly favors those who are fluent in Spanish, and we believe this will be very helpful in improving the club and improving the work that we do. And we also currently introduce Spanish-speaking workshops in our club trainings. And this is really helping students start to understand how to interact, even in smaller ways, with patients to make them more comfortable. All right, thank you. That's what I'd like to talk about from my end.
All right, thank you, Jordan. We'll go one more slide over. Yes, so that brings us to the volunteer trainings themselves. We have 3 total trainings. First is going to be the shift leader training. This is also an introduction to our shift leaders as to their responsibilities. While they should know it, it's a great time to remind them. Typically, it's an informal training where we bring all of our shift leaders to Ben Taub, and we usually hold 2 dates. So this is around the recruitment time, and we bring them, make sure they know their role as shift leader, where they need to go in Ben Taub, and really just ensure that they are going to be able to complete the attendance and reflection forms and act as a liaison between our board members and our general members. The purpose of this training is really to instill confidence in them. It's been a summer, they may have forgotten their role as a shift leader, or they might be new to the role. So we go ahead and take them through that. It's also important to mention, as Jordan had already said, that all of our trainings are going to be planned and led by our volunteer education co-heads. And so, yeah, that brings us then to our general fall training. A couple clicks over. One more. Thank you. So this is arguably, whoops, back one. Arguably one of our most important trainings. This is where we have a first formal introduction to our new members and returning members. And this is where we'll go over our shifts and what to expect in a PDI shift, as well as how to attain badge access. So that is greatly aided by Courtney. Often Courtney joins us at this training as well. And then how to uphold the PDI mission statement and really what that means. So the purpose here is to go over our shift procedures. So what is a discharge? What is a screening? How do we do follow-up calls? And we then allow members to practice in a group setting. So we have, it's usually a 3-hour training. The first hour and a half-ish is going to be a presentation from our volunteer education co-heads. And then we allow the rest of the time to be spent in groups where the volunteer education co-heads have gone ahead and created groups of returning members mixed with our new members so that they're able to practice before even going to the hospital. This is where we really go over that cultural competence, as well as what are our resources, what can we offer patients, and what is on track for our new members. And then in the spring, oh, and I should mention with those trainings before, we do have them before we go to shift. So before any new member steps in Ben Taub, they will attend our training first. And then our general spring training. So at this point, all PDI members should be knowledgeable about all activities in PDI, and they should be capable. Everyone should be badged. But we do go ahead and remind members of our expectations, and then we do announce opening board positions. Again, this is huge for our longevity. Any large group meeting goes ahead and introduces our club just to the large group as a whole and how they can become more involved in the following years. So the purpose here is not necessarily to remind members of how to do screenings, but to go ahead and go through continued education over our resources. We do resource deep dives, we call them, where we go in depth about the eligibility for patients, and then also just how we can help them more in depth in difficult situations that we see often. And then we also, this is where we have our Spanish translation and just practice with our members. So here we pair bilingual speakers with speakers that are proficient or at least proficient in PDI Spanish. We go ahead and practice and work through different approaches with that. And then it's also a time to practice the translator because sometimes it's hard to do in shift without having previous experience. So that's where we give them time to do that. And then of course we have our announcements, and this is really what keeps PDI growing and active, is that we have these large gatherings and then we go ahead and tell them how to get more involved and continue along their university experience. So that brings us to the actual shift. Let's say we're fully trained now, we've recruited everyone, we're ready to start shifts. So shifts usually last around 3 hours, 2.5 of those being actual working hours in the volunteer office or in the course. We typically advise our members to meet up at campus and then walk or drive to Ben Taub together. And then once we arrive, we're going to go straight to the volunteer office. This is another huge shout out to our institutional leaders. Having Courtney and that connection is huge. First of all, our volunteers get to leave their things in the volunteer office, personal items, as well as all of our forms for PDI. So we also keep everything in paper. So that leaves us to our follow-up bins and all of our resources. So the first thing we do is go through follow-up calls. So these are our previous screenings that we've already done from the week or month prior, and we go ahead and pull out those papers, look at those forms, and perform those follow-up calls. And then we also at the same time are checking our resource bins because we usually have these large file bins that we keep organized, and that is a position that we have is an office manager, and they keep us organized for the entire club. But it is each shift's responsibility to make sure that they have sufficient papers, screening forms, and resources for the patients. And so we'll make copies at this time as well. So following that, we will go ahead and head down to the course, and then we will go straight to the nurses and ask if they have, well, first introduce ourselves, and then ask if they have any discharges at that time. And if they do, we'll go ahead and proceed with those. But in the case that they don't, we go ahead and move into screenings. So I will go ahead and mention kind of how those work. First, the discharge process, if we can go two more over. This is typically a hospital-dependent process. At Ben Taub, we use the after-visit summary. We'll just go ahead and do a walkthrough with the patients about simple things like, do they have a follow-up appointment? What are their medications? How are they going to get that prescription? And then we'll take them to the registration desk for discharge. And this is huge for us as with our mission statement to ensure the medical adherence of their prescription or follow-up appointment. We will note down when it is and what they have, and then we are able to bring that up in the follow-up call. So that's something we do simultaneously as we walk through with the patient. And then let's say there weren't discharges or we already completed the discharges, we'll go ahead and do a screening. So our screenings are typically just a survey that goes through different questions that are looking to screen for certain resources. On the right, I have those resources here. All of these are going to be pre-approved by Harris County through harrishealthcares.org. And nearly all of these have multiple programs in Houston with different locations. That is, of course, with the exception of the Gold Card and SNAP and ECHOS. But if I were to give you my food screening or my food resource, it's going to have anywhere from 8 to 10 different food banks, for example, with different locations and times available. So then we've completed all of our discharges and screenings. We're going to go ahead and head back up to the volunteer office. We'll go ahead and file away our forms so that we can do the follow-up calls the following week. And then we have our shift leaders complete the shift reflection form. So it's a pretty simple, quick form. It informs us as co-presidents and the board of shift attendance, a few statistics that can be used for our research committee. And then we also at this point keep up with ideas for improvement in PDI, another thing that's crucial to our longevity. And then with follow-up calls, just a quick mention of those. Again, I have our mission statement here. It's important to point out that we are looking to improve the post-hospital quality of life for patients. And this is really how we intend to do that with the follow-up calls. If I see that I had a discharge a week prior, I'm going to go ahead and call them, ask them if they've been able to get their prescription, remind them of their follow-up appointment. And at this point, obviously, I am not a doctor, so I cannot ask them, do you have any questions about this? But I just try to serve as a reminder. Now, with the screening, though, I can ask them, do you have any questions? And I try to help them through the resources. For example, we see a lot of people that are applying to the Gold Card, and we are able to go ahead and help them along with that, and then ask them about application statuses, of course. So our follow-up call process is typically this can be decided institutionally or by the program. For us, we have it decided by our research committee. For the sake of time, I won't go through it entirely, but if we click through the following slides, it goes through a flow chart of our follow-up calls. We try to do 2 calls. Oh, unfortunately, the arrows are in the wrong spot. I apologize. But yes, we tried to do 2 calls, a 1 week and a 1 month follow-up call. And this is, after this, we archive it and then we use it for research, which I will let Andy get into.
Thanks, Abby. So for the people just joining in, I'm Andy, and I'm one of the research committee co-heads in PDI. I wanted to take this opportunity to briefly introduce the research committee and go a little more in depth on how our student-run committees are organized and how they actually function. As Jordan said, research committee is just one of 8 committees, but they generally all have a similar structure. Like other committees, there are 2 co-heads, and we have around 10 to 15 undergraduate students who, based on interest, joined our committee. Now, research committee primarily has 2 different arms that we engage in. The first are independent research projects and initiatives that are proposed and run by students. In research committee, we really like to encourage our students to take lessons and experiences that they gain directly from volunteering in the emergency department and translate them into research projects. And so in the past, we've created initiatives that have helped increase patient awareness and engagement with HPV vaccines, mammograms, and we're currently running a project where we're providing hypertensive patients with home blood pressure monitors. The second arm of what we do is quality improvement. I think that's going to be much more relevant to our talk today. I'm going to talk a little bit more about it in the following slides. But really, this is just one of our key measures that we have to ensure the long-term sustainability of our program. Jordan mentioned that earlier that institutional leadership is really important to the success of a committee through their guidance, experience, and network. The research committee co-heads, myself included, work closely with Dr. Zhang, who is our research and physician advisor. And he really provides us with the direction and advice for the projects we work on and connects us with additional resources such as clinical and research staff at Baylor College of Medicine and Harris Health. I think without him as an institutional partner, it would honestly be very difficult for us to independently complete any of the projects that we work on. Speaking personally for myself and many of the undergrads that I also work with through research committee, it is many of our first times working directly with clinical patient data, and it is why like institutional leadership, especially in a context like research committee, is so important. So I want to go on a spend the next section doing a deeper dive into our quality improvement study. As I said, it's not only a big part of what we do in research committee, but it's also vital to the longevity and sustainability of a program like PDI as a whole. So here's like the workflow that we use in our quality improvement study. Um, so for some background, I know it was the last slide, but the PDI-QI study has been in place long before I became co-head of the committee last year, and it's something that we continuously run year after year to maintain the standards for our PDI program. And we're only able to do this through a submitted and ongoing IRB with Baylor College of Medicine as well as Harris Health. And this really allows us to collect, analyze, and publish patient data. So for our workflow for quality improvement, our pipeline starts with data collection in the emergency department. Abby talked about this. Abby talked about this earlier, but this is where PDI volunteers will provide patients with a physical social needs screening or a discharge form that they're able to fill out in the emergency department. At the end of a shift, the completed screening is then filed for a follow call, and both the 1 week and 1 month calls happen inside the volunteer office as opposed to the emergency department where the initial data is collected. After we've done our due diligence at contacting patients at both 1 week and 1 month for follow-up calls, we close the patient's file, and the student volunteer will input completed patient data into REDCap. This is a secure platform that many of you guys have probably heard of or are familiar with, and we use it to manage our surveys. This step essentially digitizes our files into an organized platform and allows us to analyze the data. I want to emphasize that the process thus far is like very hands-off at an administrative level, because both data collection and data entry are very much integrated in a normal PDI shift and are done completely by student volunteers with very little oversight, even from the research committee. All students are versed in how to collect and put in data and are taught through our club trainings. However, it's still the co-head's responsibilities to catch issues or discrepancies that may arise during data collection or entry, and address them appropriately. Um, Now that once we have our electronic records stored in REDCap, we start our data analysis. Now, this is where our research committee members become involved. Generally, the co-heads will meet with our research advisor to discuss the endpoints and directions we want to take for the review. And these co-heads will work with the research committee members to go and execute on the analysis and draw conclusions from the data. Once we organize our findings, the research committees will, co-heads will convene with the PDI presidents and we'll discuss what we found during our research. So Jordan, Abby, and myself and my other co-head Esteban sat down at the end of last semester to share our findings from our study. And now these conversations are able to inform which social and medical resources we want to add, drop, or revise, how resources are delivered at the point of contact, and how we can tailor resource delivery to specific patient populations and more. So next slide. So how do we actually track and measure like our data? First, I wanted to mention an important limitation to the type of data we are able to collect. I saw a question earlier in the chat about Epic access. So our QI study is done without Epic access, so we don't really collect any data on ethnicity, age, zip code, medical history, etc. As a result, we generally rely on simple patient-reported demographics such as the language they speak, their current insurance status. And for the patients we administer the social screener to, we track their responses to varying needs from food, housing, and transportation access to things like educational needs. At the 1 week and 1 month follow-up calls, we will follow patients' health insurance status, especially those in the process of applying to national or regional insurances such as Medicare and the Harris Health Financial Aid Program, as mentioned earlier. And we look at the resources that patients actually end up using and if they're able to pick up their medications and attend their follow-up appointments. And so we take all of this data and then we funnel them into endpoints that we track for every QI cycle. And this includes follow-up contact rates, resource demand, and utilization rates. And for every endpoint that we look at, we really want to make sure that we're stratifying that data by demographics to ensure that there are no significant discrepancies in the patient populations we interact with. Again, this is especially important considering the fact that we work within a safety net hospital where we see patients that walk through the hospital door from all different backgrounds and gives us a very diverse patient population. So to wrap up this section about quality improvement, I wanted to quickly talk over some findings that we found in our last cycle, just to see some grounded examples of how our work has been able to improve our program. So first, we found that Spanish-speaking patients were actually 20% more likely to leave blank answers in the social needs screening compared to their English counterparts. For example, when asked about if they're worried about running out of food before they could buy more, the boxes are often true, sometimes true, and never true, and they would all remain unchecked. Now, this could be the result of many things, of course, from like stigmas or fears surrounding certain topics such as substance abuse, or it could be a comprehension issue due to a volunteer not adequately explaining like why they were even given the screening in the first place and like what we provide as a PDI. Next semester, as Jordan mentioned, we're actively trying to recruit more fluent Spanish-speaking volunteers to combat this. And we'll also be adding like instructions during the next volunteer training to look for unchecked boxes and double check with the patient to ensure that they're properly understanding what these questions are actually asking. We also found that this past year, we were only doing a third of the discharges compared to than we had been doing in previous years. This is likely due to the internal growing emphasis that we've been placing on screenings and the resources which have led discharges being done less. Typically, shift leaders will ask nurses if they have patients for us to discharge. So for this year's shift leader training, we want to emphasize them to ask nurses like each shift for discharges and make that a habit. We also found that there were lower requests for immigration and legal resources, likely to recent events. And now we're going to include this in our volunteer trainings for volunteers to emphasize that their conversation with the patient will remain confidential and information such as legal status will not be disclosed to others.
Great. Thanks, everybody. We're going to finish up by talking about possible expansion and thinking about introducing programs like this in different settings. Currently, we're supporting a group of students at University of Houston, undergraduate students, to expand a patient discharge initiative to the other county hospital in Harris County, LPGA. And so going through these steps and thinking about who can be involved and what are specific steps you need to consider to introduce a specific program like this. So there's many, many different types of stakeholders. You have your EC physicians and nurses and other advanced practice providers. And then any available case management service that's based in the emergency department. This can also include your registration team, which at Harris Health is the patient access management team. It's really important to engage this team because A, they can tell you about existing resources that are being provided to patients in the emergency center, and B, for patients that are requiring financial assistance or application for eligibility, your registration patient access management team can really assist with those discussions. We've definitely used meeting with these teams to inform our resources and how we've changed our scripts and how our volunteers approach patients. We've talked a lot about volunteer services at Harris Health, but there's many different potential committees and services within your health system that you might need to consider engaging, whether that's a volunteer services office, any public health or population health office, any patient engagement or patient accountability office, and then quality improvement teams looking at outcomes. On the university student side, engaging with the University Student Activities Office, so specifically looking at rules around the student organizations, what resources are available, both monetary and supplies. And then lastly is all of the network of resources to address social needs that is available in your community. We've really tried, especially during COVID, we tried to expand more and talk more with the organizations that we were actually referring our patients to figure out, what is a better way to do a warmer handoff, what are services that they might need to help support patients that are referred to them. And this is something that, would be great to continue to support and engage with. In terms of the actual steps, the first is really to gauge needs and interests. We were really lucky at the beginning of this organization and throughout the organization's existence to have really strong support from Harris Health, both from the volunteer services offices and the population health office. There was a question about Epic Access, and CHW formalization. And we really did want to push, and Harris Health wanted us to really formalize our student cohort as CHWs in the emergency department. Rice University and Harris Health went through a multi-year process to create an MOU for this to happen. And this is something that we're still working with Harris Health to implement. But as of now, it's not, we haven't advanced with the formalization, and we haven't advanced with that would be the Epic Access and Epic documentation, but it's something that we do hope is possible in the future. That goes along with also the feasibility and credentialing in general. So of course, what training and what certification and what protections are taught for those who are registered as volunteers, research assistants. Those are different rules for different cadres. And so we do our best to adhere to all of the regulations through Harris Health and Baylor College of Medicine and Rice for that. And then we went through sort of all of the different training processes, resource development, resource and quality improvement, and the recruitment and training for those volunteers. So really having an iterative process where you put something in place that's informed, you have a good feedback process for from all of the stakeholders, including the volunteers and patients, and really feeding that back in and improving the process in the organization. Next slide, please. So I'm happy to finish off with a few testimonials from the volunteers. You can read them here, but one thing I like to say when I joined the fall training for the new volunteers is that many of them are interested in careers in the health professions, whether medicine, nursing, physician assistant, other allied health positions. And I tell them, to be a health professional, you go through professional school. And as an undergraduate student, talking with these patients, learning about them, their needs, talking about their experiences, this is actually the closest you'll be to being a patient. Because the longer you go in your training and the more professionalization you undergo, the different perspective you might develop. And I think it's really wonderful that our volunteers really have this experience to talk with patients early on, to talk about their needs and to help them formalize them and to help inform their own development into a health professional. So with that, I think that's all the slides that we had prepared. I'm happy to jump into questions. Thanks, everybody.
Great. Thanks, everybody. That was an excellent presentation. It's very impressive what a broad and large scale operation this is and how you've been able to systematize it and standardize it and ensure quality. I'm going to go, I know folks are dropping questions in the chat, and I know you touched on a couple of those already. Just to kind of clarify or pick up where you left off, you both, Dr. Zhang and Andy, talked about not having access to Epic, but you do have your own REDCap system for monitoring outcomes. Does that information make its way back to the treatment team or the electronic record in any way to know what services were received and how they relate to health status?
Yeah, unfortunately, not in real time, and not sort of on like a monthly basis. In addition to using the quality improvement information to inform PDI, we also share our quality improvement information with Harris Health. So there's an annual Harris Health Scientific Day that we often will participate in, present our information, but we also have had regular meetings with population health and with nursing leadership in our emergency center to say, hey, this is what we've observed, and this is the resources that we've given. In our past iterations, our experience mirrors the rest of population health's experience in the other pavilions in terms of patient needs, patient demographics.
Great. Another question from Deborah Siemens was, given the nature of having volunteers and students involved, is there support for someone if they get stressed or, experience something that's kind of difficult to process?
Take this one. First, that's a fantastic question, and it's very important. I want to mention that a lot of the students get into this organization, obviously specifically to help the underserved communities in Houston, but also to get experience with particularly that. Many of the students are pre-medical, and they know these are types of conversations they will experience as a medical professional, whatever field they end up choosing. And being able to do it in such an intense environment as Ben Taub, as maybe one of your first experiences, is an imperative experience. So when we talk about the support they have, oftentimes this comes from the shift leaders. This is why we take shift leader applications and selection so seriously, because these are more experienced, often upperclassmen undergraduates who have now done this for multiple years and may have even had clinical experience prior to undergraduate education. And these are people who are then experienced and able to handle these sensitive conversations, know how to prevent it from getting into their personal lives, know how to separate. Obviously, more as undergraduates, this is something we're continuously working on, and we're no experts at it like a physician would be, but they have the resources such that they can help their fellow students combat that. And this is also something introduced in our training. In addition to that, we also, as a student-run Rice University organization, we always have resources at Rice University available for mental health support, psychiatric support, if that becomes available. That is something all students are very aware of.
For this kind of work, it's a really important part of our workforce are the community health workers. And actually, Dominic asks, have any of the students gone on to pursue certification as a community health worker, either as part of this program or independently?
Right now, we do not have any pipeline to then become a community health certified worker. It's a very interesting topic. It's something we should certainly look into, but currently it is not something that we have students certified for.
Great.
I will
We've
say that
had
many students are very interested in public health. I would say many of the students are interested in public health. If not pre-medical, they're interested in public health plus pre-medical.
we've had a few previous board members, co-presidents, and community leaders who have become interns at the Harris Health Population Health Department to help with their activities. And some of them have also gone on to directly go to public health school.
Great. Kelly Paul asks, are phone calls the main follow-up method, or do you use texts and emails or other ways to try and get a hold of folks?
Yeah, phone calls do tend to be our main follow-up method. Starting this year, we have actually started to try to branch out from that, including access through Doximity, and I'll let Dr. Jong follow about that. But typically, this would be used when a patient doesn't answer the phone, if there's something that we find imperative that we want to send them, or just simply they're like, I lost this resource, I had really wanted it, we would send it to them at that time as well.
Yeah, traditionally the volunteers would call from the volunteer office within Ben Taub, and so their caller ID would come off of Harris Health. That's been scripted into the patient in our counter that to expect a phone call from this number. There's a specific questions to ask. Are you sharing your phone with other people? At what time is it best to reach you? So that we can really set up for success for that follow-up call. Because we know that a lot of our patients are sharing phones with other folks, are screening phone calls. Many people don't answer unidentified phone calls anymore to begin with. And then just as Abby mentioned, we have been trying to use Doximity with the Harris Health caller ID to reach patients and follow up as well.
Thank you for that. And Catherine McDonald had a question, and she also mentioned Doximity. Catherine, I want to make sure we're fully answering your question. Did you want to unmute yourself and come on and talk about what you're wondering about Doximity? Catherine McDonald.
Hi, I was just wondering how you masked your calls, especially with multiple users, and what kind of system you are using to stay HIPAA compliant.
Yeah, we have a so our for our patient information, it's securely stored in the volunteer office. So within the volunteer office, which is already a locked room, there's additional locks for any of the papers that have patient information. The red cap is an approved Baylor HIPAA compliant information storage. And then for the phone calls, what we do is we have a couple iPads to help with introducing resources to patients at the bedside. And so those are protected tablets that stay in the volunteer office, and those are the ones that we use for Doximity.
Thank you.
Gardner says you have a high success rate with reaching people on follow-ups. What do you attribute that to?
I would say, first of all, just our real conversations with patients. I obviously, when the call comes through, it says Harris Health, but they did speak to volunteers, and often we really try to focus on the quality of our patient interactions over the quantity. Just meaning when we go for a screening, we explain to them what we're screening for, and really that it's not for us, it's not a hospital survey that you just are kind of, we're hoping that you do. It's trying to connect them to resources. And in that, we're really just hoping to help them and make that the emphasis. And so hopefully when they see that call come through from Harris Health, they had a positive experience with us as volunteers as well as the medical professionals. And then hopefully we get to call them back. We do also tell them that usually that we are going to follow up in a week and a month. So hopefully they're already expecting it. And then, yeah, we just go through their questions with them and hopefully then they call us again a month later.
This next question's not so much about the Patient Discharge Initiative, but more about Baylor College of Medicine and their curricula there. It's just asking about, given that you identified this need for Spanish-speaking health professionals, what kind of things are in the Baylor College of Medicine curriculum to prepare folks for Spanish conversation?
I think, if I'm not mistaken, there is a Spanish medical elective for medical students. I'm sorry, I'm not directly involved in medical student education at Baylor. I do mostly resident education. And so for residents, we also have a lot of support for patients. Our residents are interested. We, in our emergency medicine residency, have developed a Spanish elective for resident physicians who are interested. And then our language services at Harris Health are just phenomenal in general. So we have medical interpreters 24/7 physically in our emergency department. And then we have the phone line that we use. That's usually what the volunteers use. Really, the language line services are available to anyone with a Harris County badge, which is the volunteers include have an ID number. So that's one way that we can sort of use that. Harris Health also has a one-time bonus for certified bilingual employees. So a lot of our nurses, our medical assistants, emergency technicians, they benefit from being bilingual by having the one-time bonus. I think that that's still something that can be further promoted and supported. And I think, I'm sure you all know there's plenty of literature that shows that having a certified bilingual physician or nurse really does improve patient outcomes from the emergency department. Thanks.
Great, thank you. I just want to acknowledge Deborah Siemens dropped in the chat a link for the State Department of State Health Services and their management of the community health worker certification. So if you're interested in learning more how to be certified, you can follow the link in the chat there. And we still have a few minutes, but I think we've touched on all the questions. If I missed your question or you haven't had a chance to pose your question yet, I'll please unmute yourself and come on and hit us with what you're thinking about.
Wanted to go ahead and touch on, I see a question that I think we can go a little bit more into. It was from Ashley Dominic, and talking about improvements in health outcomes as a result of social need referral. A lot of what we can do and what we intend to do is reduce the number of ED revisits post seeing the Patient Discharge Initiative. As we know, ED revisits is a large burden on safety net institutions or any hospital, but also on the patient. And often we can attribute many of those correlates to the social determinants of health. So the research committee has conducted in the past studies on seeing whether our interventions are helping in those ED revisits. And if you're interested, there's a 2021 abstract published in the Annals of Emergency Medicine that shows that we helped with our intervention reduce the likelihood of an ED revisit 90 and 30 days post-discharge for many of the sensitive and vulnerable population groups. As for the health outcomes, because we don't have Epic access, as we spoke about earlier, that's not something we can directly track whether we're improving that. But seeing the reduction in the ED revisits is something that makes us very positive about the work that we do.
That's awesome. Well, okay. Aria Welch has a chat here. Has there been any particular need that your team has found most closely related to ED readmissions?
So in addition to the PDI initiative, we have a most visited patients program at Harris Health that really focuses on patients that have more than 5 ED visits in a 2-month period. And so for a lot of these patients, we've noticed that the drivers are experiencing homelessness, psychiatric illness, comorbid substance use disorders. And so we do have a dedicated community health worker who is part of Harris Health, who is in the emergency department in the afternoons and evenings to help screen these patients, address their needs as well. I would say that for the patients generally that are approached by the Patient Discharge Initiative, they are sort of patients without these multiple ED visits and are often benefit from this one-time screening and referral to resources. It would be interesting to see if we can look and see if there's any other predictive factors for frequent ED visits or admissions. But that's what we've seen in our experience.